Thank you for that introduction. Again, I'm Adam Scaff. I'm a pediatric cardiologist here at Norton Children's Heart Institute, and we'll be discussing red flags during sports participation exams and some indications for cardiology referral. I have no disclosures to report. And some of the objectives for today, again, we'll be discussing red flags for underlying cardiac disease during sports screening evaluations. What is the threshold for referral to pediatric cardiology? And then what do we do as soon as you send patients to us for cardiac clearance for sports participation? And I wouldn't really be able to talk about sports pre-participation exams without talking about the reason why, which is to prevent sudden cardiac arrest. And Project Atom is a group that we are now a part of, promoting community cardiac emergency response preparedness. So that's something I'll touch on at the end. So a little bit of background, again, pre-participation cardiovascular screening in young athletes. The main point of this is to prevent sudden cardiac arrest, which leads to sudden cardiac death. It's leading cause of death in young athletes during sports. That screening is vital in detecting young athletes who are at risk, who may not otherwise know they're at risk. And symptoms with exertion may be a clue to underlying cardiac disorders, so a detailed history and physical at these visits is very important. So again, talking about the background, sudden cardiac arrest in pediatrics is not uncommon. It's less common than in adults, but it does happen. There's a 4-to-1 male to female predominance. 2/3 of those in pediatrics will occur during exercise or with activity. The incidence again is less than the adults, 3 to 8 as compared to 52 per 100,000. And again, cardiac arrest is not necessarily a circulation problem, but an electrical problem, usually a disruption in the electrical system leading to sudden cardiac arrest like ventricular fibrillation or other malignant arrhythmia. So again, who is at risk? This is the thing that is scary, and this is the reason why we have a very robust screening program to sort these kids out. Kids of all ages, even though they are overall healthy, may have underlying risk factors that are unknown that place them at risk for sudden cardiac arrest. So if we think about the general population of kids that we are treating or screening in the United States in youth sports, there's about 75 million school-age children. Half of those are on sports teams or do something physically active. That equates to about 8 million high school athletes that would be receiving screening nationwide. That's a lot of kids that we have to screen to keep them safe. What we're looking for and what things kind of stand out for who's at risk. There are always kids that may come to clinic that have a history of congenital heart disease. Those kids are likely already plugged in with a pediatric cardiologist, and they should seek clearance for sports from their pediatric cardiologist, not their primary care provider. But really, the ones that will be picked up in the community and at primary care offices are ones with undiagnosed conditions. Things like cardiomyopathies, which can be inherited, hypertrophic cardiomyopathy, dilated cardiomyopathy, or left ventricular non-compaction, channelopathies, which are your malignant arrhythmia syndromes, like long QT, Brugada, catecholaminergic polymorphic ventricular tachycardia, which is a mouthful, but that's one that we do see that is associated with activity and sudden cardiac arrest, and then Wolff-Parkinson-White. And then conditions that cause connective tissue breakdown or abnormalities in the aorta, like Marfan syndrome. So things that can be picked up on a physical exam. Other things, it's important to screen about exposures. And so are kids taking medications or maybe they're having caffeine overuse? Those types of things can present as cardiac symptoms. They may not be necessarily increasing the risk of sudden cardiac arrest, but the symptoms that they describe may be due to other things that they are ingesting or putting in their body. Infection, any patient with a prior history of myocarditis in the recent months is typically restricted from physical activity, and they would need clearance from a cardiologist prior to returning. This last one is one we can't really screen for, but this does cause sudden cardiac arrest in sports, trauma to the chest or commotio cordis. This was kind of made famous by Damar Hamlin on Monday Night Football a couple years ago, which has increased the community awareness in sudden cardiac arrest prevention. So a blunt force trauma to the chest leading to ventricular arrhythmia and sudden cardiac arrest. So warning signs and symptoms are present in 20 to 40% of sudden cardiac arrest events, but often ignored. Fainting, chest pain, palpitation, shortness of breath, really anything with exercise. If exercise makes it worse, those are things that are typically red flags for me when I hear those things in the story. Symptoms at rest sometimes can be related to underlying cardiac abnormalities, but by far and away, those are the ones that are more related to stress, anxiety, or other types of factors as opposed to underlying cardiac disease. So, as far as the key elements of a pre-participation screen, one of the things that I think is very important is that these screens should be performed at the patient's medical home. The primary care provider is the person that knows the patient and their family the most. They have the best rapport. They follow them a lot of the times their whole life, and now they're being asked to screen them for participation in high school sports. And so it's also important to get information from the parents in order to have an adequate history. And so for medical history, it's not only the past medical history of diagnoses or medicines that they are on, but if they are having symptoms, when did those symptoms start? What things are their triggers? What things make them worse? What things make them better? Those are all clues into the underlying etiology of the symptom and are they cardiac or not. As far as family history, again, inherited disorders or history of early sudden cardiac death, which I'll touch on here in a bit. Physical exam in the pediatrician's office, you're typically doing full exams, and so it's probably more detailed than ours. But really, for cardiac purposes, we think about pathologic murmurs, kids with hypertension, they should be screened for underlying cardiac issues. And then any sort of stigmata for connective tissue disease typically will require at least one-time screening echo to rule out things like aortopathy or aortic root enlargement, like with Marfan syndrome. Mental health screening and substance abuse screening, again, those are two things that aren't necessarily as touched on the sports screening forms. But I always say that these are very important because sometimes underlying mental health issues can manifest as cardiac symptoms, especially anxiety. Again, palpitations, chest pain, shortness of breath while you're sitting in class or getting ready to give an oral presentation, more likely to be stress and anxiety related as opposed to cardiac in nature. And then substance abuse screening, as I mentioned before, the big one we're seeing these days that lead to cardiac symptoms is caffeine overuse. There's a lot of energy drinks in the community. Younger kids are now carrying around different energy drinks that have way more than the recommended amount of caffeine intake for a child their age. And they're being seen for palpitations and chest pain in local emergency departments. Most of you are probably familiar with this form. This is the 2023 version. If there's a newer one, I couldn't find it. But this is the one that I used for this talk and is the Kentucky High School Athletic Association pre-participation form. I really just took the screenshot of this section because it has the heart questions on it. And so I was going to touch on each of these and give a little bit of a deeper background. And so again, the heart health questions about you. Most of these are related to symptoms, especially with exercise, and they are very specific, saying during or after exercise for most of these. Have you ever passed out or nearly passed out, had discomfort, pain, or tightness or pressure in your chest, heart racing or fluttering? So that's the palpitation question during exercise. Then it gets into a little bit of the heart history questions. Has your doctor ever told you you had a heart problem? And if they have you followed up with a cardiologist, or what did the cardiologist say at their last visit? Did they say they needed further screening? I will say, at least most cardiologists, especially everyone in our group, at the bottom of all of our clinic notes, we have the clearance for sports. There's a line that says physical activity. It'll say cleared for sports or varsity sports, or it'll have restrictions. And so, if there's ever a question, if you've referred someone, if they are cleared or not, the last three lines in our note always have that recommendation. And then, has a doctor ever requested a test for the heart, like an ECG or an echo? That's an important question because the question I always bring up is where were those performed? Where were they read? Pediatric EKGs specifically sometimes have subtle abnormalities if read by an adult cardiologist. They might think that is pathologic as opposed to just a normal variant for a teenager or a skinny high school athlete. And so it's important that if you're getting the test, that it's being interpreted by someone trained to read pediatric studies. And then if there is a test that is performed that is abnormal, having follow-up for that test with a cardiologist. And then 9 and 10, lightheaded or short of breath during exercise. Again, it doesn't really point to position changes or during class. And then have you ever had a seizure? This one may not necessarily be talking about truly seizure activity, but kids who have a syncopal event while exercising can often have abnormal movements that may be related to an underlying cardiac issue. And so sometimes events can be labeled a seizure, which may actually just be some abnormal movements after a brief sudden cardiac arrest event that was aborted. And then these 11 through 13, these are really the family history questions, which I'll touch on here in more detail. But has anyone in the family passed away unexpectedly before the age of 35? This is a very specific statement here, drowning or unexplained car crash. Those two examples specifically are trying to lead you towards, is there an underlying heart rhythm disorder in the family? Long QT type 1 can be triggered by swimming. And so if there's someone that was a good swimmer in the family that drowned unexpectedly while swimming at the lake, that's a red flag because maybe they had a ventricular arrhythmia while swimming. And then the unexplained car crash, the falling asleep at the wheel, that is a common story that maybe they did fall asleep at the wheel, or maybe they had an arrhythmia event while driving that led to their single car accident. And then the family history things, which again I'll touch on in more detail, are the cardiomyopathies, rhythm disorders. And then sometimes families aren't able to tell you specifically what the diagnosis was, but they know someone at a young age had a pacemaker or a defibrillator underneath their skin, and they remember that vividly. So that's something that some families may be able to tell you. As far as the American Heart Association is concerned, they have a policy statement out that includes a majority of the things that I've already discussed from the Kentucky screening guidelines. Screening should occur annually. You should obtain a personal and family history. It should be a comprehensive physical exam. They also have a 14-point screening tool. There was a paper that came out in 2019 that looked at all of the states in the United States compared to this 14-point element screening tool. And at that point in time, there was maybe 50% of the states that actually had met all of those questions on their sports forms. If we looked at that map, Kentucky was not on there, but as the Kentucky form has improved, now the Kentucky sports form actually has most of these elements. The one thing that they reiterate many times and have done studies on is that the AHA does not recommend routine 12-lead EKG or echo screening unless you have a clinical reason to. So if someone has passed their sports screening form, they have a normal exam, they do not actually recommend getting a baseline 12-lead EKG unless you have a reason to do so. The main reason, because sometimes those can lead to false positives, increase the need for further testing when maybe they don't actually need it. It is recommended that if you have a red flag that comes up on the screening form, that they do seek extra screening with a cardiologist, or if that test is warranted with an EKG or echo. Again, being read by someone trained to see what they mean. This is a clipping of that 14-point screening tool. Sorry. And you'll see here it's broken down into personal history, family history, and exam. Again, these are things that I just walked you through on the Kentucky Sports Form, so it is fairly comprehensive. Exertional symptoms of chest pain, syncope, fatigue, previous recognition of a heart murmur. The big question with that one is it pathologic or not? Um, Elevated blood pressure. So sometimes underlying uncontrolled hypertension, you can have a hypertensive response to exercise leading to chest pain or pressure with exertion. Has the child ever been restricted for some reason from sports? What was the reason? And do they need repeat clearance from a cardiologist based on that reason? And then again, prior testing, what was the outcome and what was the follow-up recommendation? Family history, we already discussed. And on the physical exam for heart murmur, again, pathologic, and they specifically describe at the bottom, performed in many positions and with many maneuvers like Valsalva to try to unmask murmurs that are due to left ventricular outflow obstruction. Femoral pulses and blood pressures in the arm and leg also help you rule out things like coarctation, which may not have presented as a baby, but now are presenting as high blood pressure in a teen. And then any stigmata of connective tissue disease is something that typically will need screening by a cardiologist. So for the medical history, these are just a couple of additional points I wanted to throw in. Again, kids with prior cardiac surgery or unrepaired heart disease that we know about, they should really be seeking clearance for sports from their cardiologist. And if they have not seen a cardiologist and had the history, they should be re-referred in case they were lost to follow-up. That does happen. Periodically, we'll get kids in clinic that maybe had not gone back to the cardiologist after several years. There was a COVID pause where people didn't electively go to see their cardiologist or clinic. I think that was probably across the board with all subspecialties. But some kids are coming back having not been seen for 4 or 5 years and need rescreened if they had a problem in the past. Known history of cardiomyopathy or arrhythmia disorder. These are kids that are usually plugged in as well with either our heart failure or cardiomyopathy clinics or our electrophysiology team. These types of disorders don't necessarily keep you from participating, but they definitely need evaluation and management of those disorders because some kids can participate safely if they have the proper safety nets in place, like medication, or maybe they had an ICD placed for an arrhythmia disorder. Again, recent myocarditis history. Typically, after a clinical diagnosis of myocarditis, if someone's admitted or if they have MRI evidence of cardiac inflammation or scarring, they require a minimum of 6 months of exercise restriction. And prior to returning to sports, they typically have a repeat evaluation with a cardiologist with an echo, cardiac MRI, and a stress test to rule out any ventricular arrhythmias that occur with exertion. So again, if you're seeing someone in follow-up and they're diagnosed with myocarditis, they need to be cleared by a cardiologist before returning to sports. One that I think we don't think about as often, we think about the disease process of Kawasaki disease a lot, especially in pediatrics, younger children, 6 months to 3 years of age, coming in with fevers, swollen lymph nodes, rashes, irritable. And we always screen initially when they're diagnosed clinically with Kawasaki disease with an echo to look and see if we have coronary artery dilation because it's a medium vessel vasculitis process. Kids that have had actual coronary aneurysms with their Kawasaki diagnosis that require treatment, typically moderate or large aneurysms, those children need screened in the future when they're teenagers trying to play high school sports. A vast majority, thankfully, of kids that get diagnosed with Kawasaki disease have mild or no coronary artery involvement. Those children do not necessarily need screened as young adults, but kids who are on anticoagulation or had long-term follow-up with cardiology because of large aneurysms, they absolutely need screening as teenagers before playing varsity sports. And then again, symptoms with exertion. One of the things I wanted to point out is that palpitations that precede the other symptoms are more concerning. So if a patient says the first symptom I feel is my heart starts racing, then I pass out, or then I feel short of breath, or then I have this chest pain or pressure, that may be actually more indicative of this rhythm being the main problem as a malignant arrhythmia. So as far as the family history questions, just wanted to briefly touch on the types of cardiomyopathy that we commonly can see. Again, hypertrophic cardiomyopathy in this top left panel is one that most of us will be listening for with our cardiac exams and maneuvers. You will have dynamic left ventricular outflow obstruction. This is an echo picture showing the asymmetric septal hypertrophy. This is usually something that can be inherited due to the myocardial gene defects. Bottom left, dilated cardiomyopathy. Again, you get thinning and enlargement of the left ventricular wall. All of that can lead to poor function, symptoms with exertion like fatigue or exertional dyspnea, as well as because the myocardium is abnormal, ventricular arrhythmias leading to sudden cardiac arrest. This top right panel, arrhythmogenic right ventricular cardiomyopathy, you get this fibrofatty deposition on MRI in the right ventricular wall, and all of that deposition leads to malignant ventricular arrhythmias that can be seen as well as exertional symptoms leading to sudden cardiac arrest. And then the bottom right panel, left ventricular non-compaction, you get dysfunction, you get really coarse trabeculations as opposed to the kind of smooth wall you see here. You get very coarse crypts and trabeculations that can lead to ventricular arrhythmias, but also thromboembolic events because little clots can form in these little crypts in the wall, leading to sudden cardiac arrest events. Now going through some of the arrhythmia syndromes, Wolff-Parkinson-White, one that most people are familiar with by the pathognomonic EKG finding of a delta wave or the upsloping on the QRS, leading to a short PR interval. This is due to an atrioventricular bypass tract that bypasses the usual conduction system with the AV node and the His-Purkinje system. And so this sets kids up for reentrant supraventricular tachycardia. The reason that this can also set you up for sudden cardiac arrest, because if a patient went into atrial fibrillation, you can have rapid conduction across this extra pathway, which can lead to a rapid ventricular response, followed by degeneration into ventricular fibrillation, leading to sudden cardiac arrest. And so kids who have this EKG finding, typically we will refer, even myself as a general cardiologist, I will refer to the EP team, electrophysiology team to do a risk stratification of their WPW. And if they meet criteria, they can go for electrophysiology study and possible ablation if necessary. So typically, if I see a patient like this, if they're asymptomatic and have never had palpitations as an incidental finding, I don't necessarily restrict them from sports immediately. But if the patient comes in with palpitations and that was the reason for getting the EKG in the first place, I will typically restrict them until cleared with further testing. Some of the channelopathies and arrhythmias that are more inheritable, long QT syndrome on this left panel, prolongation of the QT interval. One of the ways that you can kind of just quickly look at an EKG is if the QRS to T wave offset, the QT interval, is more than half the distance between the QRS interval. That usually means it's probably prolonged. There are different types related to different gene defects. Type 1 is the one I was alluding to earlier that is triggered by swimming. So that's the history question of did anyone drown unexpectedly? Because that can be triggered by a swimming event. And this long QT typically leads to torsades, which can lead to sudden cardiac death. This middle panel, catecholaminergic polymorphic ventricular tachycardia. This is a catecholamine-sensitive ventricular arrhythmia, meaning as you exercise, your catecholamines surge and you are at risk for sudden cardiac arrest. You can typically get this kind of odd-looking, what we call bidirectional polymorphic ventricular tachycardia, and this is due to a gain of function mutation in a ryanodine receptor in the cardiac myocardium. Ryanodine receptors regulate calcium from the sarcoplasmic reticulum, and this sets you up for ventricular arrhythmias and sudden cardiac arrest. These patients typically will be on beta blockers and also have ICDs potentially, but mostly beta blockers. And these patients are often restricted from activity completely. And then Brugada syndrome, this is a loss of function most commonly in an SCN5A gene. You can see this, what we call coved ST segment in V1 and V2. It's kind of a very abnormal ST segment, and it puts you at risk for ventricular fibrillation and tachycardia. And these patients can present as syncope or sudden cardiac arrest. As far as the exam findings, these are things that you all are doing at baseline. Again, if you have the feeling that a murmur is pathologic, it's greater than 2 out of 6, it's harsh, or it has the kind of classic findings with maneuvers like Valsalva, that usually requires a referral for further evaluation. And then again, the stigmata of Marfan syndrome, the Gantt criteria I just put here for your reference, which most of you probably already know. But really the main reason for cardiology referral is because 4 to 7% of patients diagnosed with Marfan syndrome can have sudden death with exercise due to aortic root dilation and dissection. So now that we've had the red flags come up and we refer to pediatric cardiology, what will we actually do? Everyone that walks through our door gets a 12-lead EKG. That is standard. We always do that to screen for these sorts of things. But if they're going to be seen in a cardiology clinic, it'd be very unlikely that they would not have a 12-lead ECG. If it is not urgent, I always advocate for waiting to do the ECG because we will be interpreting at the time of the referral. If it's something that's needed sooner and you just need answers sooner, then by all means, EKG is appropriate. Just making sure that it's interpreted by someone trained to look at pediatric EKGs. Again, a focused physical exam will listen in all the maneuvers, with all the maneuvers and positions as usual to try to pick up on pathologic murmurs. If there are dizzy symptoms or syncope, we will often do orthostatic vital signs to rule out things like orthostatic intolerance or other types of symptoms that may occur with non-cardiac conditions. An echo will be obtained if there's an abnormal exam, EKG, pertinent family history, or the symptoms are concerning enough to screen with an echo to look for underlying cardiac abnormalities. Holter monitors of varying durations can be placed if the patients have palpitations or otherwise. And we will typically place them and then send them home and have them go about their usual routine. The only time I will tell the patient not to exercise with a Holter monitor on is if I think their symptoms are severe enough to warrant full restriction until further testing. That further testing is typically a treadmill stress test. That's kind of at least initially, the end-all be-all for testing for full clearance if you are concerned for underlying exercise-induced arrhythmia or cardiac ischemia. And so those are the patients where we're still having significant symptoms. We have baseline normal testing. Now we have to do what we call provocative testing, get them on the treadmill, exercise them, and see if we can elicit the symptoms that they're having, and then identify if they have any blood pressure or EKG changes with exercise. We often will couple this stress testing with pulmonary function testing and a metabolic stress test because a lot of times underlying pulmonary pathology can also give you the symptoms of chest pain or dyspnea with exertion. So we always think about that on the back burner if there is maybe an exercise-induced bronchospasm leading to these symptoms. So a lot of our patients, as I mentioned before, already have a diagnosis of underlying cardiac abnormalities. The AHA and the American College of Cardiology actually has consensus papers out for many different types of heart diseases, and this is kind of our playbook for what screening we need to do for different types of cardiac abnormalities. And so, depending on what they're coming for, maybe a kid had repaired coarctation as a baby, and now they're trying to play sports. Maybe they were more complicated, like tetralogy of Fallot repair, and they're following with minimal residual heart abnormalities. This will tell us what we need to do before fully clearing them from sports participation. This document has these types of figures that stratify the different types of sports based on strength and endurance, high and low strength and high and low endurance. Kids with more significant heart disease that's untreated are down here in this low strength and low endurance side of things. And if you have minimal residual disease or no disease, then they're basically cleared for everything up in the high strength and high endurance category. Whenever trying to come up with the decision on whether or not we're going to let kids participate or not, it's always a three-phase approach. You need to diagnose and then treat the problem to make them as safe as possible. You need to educate the family and the stakeholders, typically the parents, in what their values and risk tolerance may be. Some kids may say, I need to play sports, and that's it. So then you have to make it as safe as possible, and you give them the recommendations that you can. Other families may say, I want zero risk, and then it's not as hard to say, I can't have you play that sport. Regardless of the decision you come to, whenever you get down to the sports participation, you need to have an emergency action plan. You need to make sure the school is safe. And that is where Project Adam comes in. I know I'm a little bit short on time, so I'm going to go ahead and do this quickly. But Project Adam is a new program that we have at Norton Children's Heart Institute, where we go into schools and help set up cardiac emergency response plans. It's named after Adam Limmel, who passed away on the basketball court as a senior in high school and was founded at Children's Hospital of Wisconsin by his parents and his cardiologist. It's a hospital-based community outreach program that implements cardiac emergency response plans for schools and communities. Since it started, 250 lives have been saved. Sudden cardiac arrest, again, is more common, and one of the keys to survival is early defibrillation. And so that's a big key for Project Adam, is making sure that AEDs are readily available in schools and people are trained to use them. We also advocate for early bystander CPR to improve survival outcomes and prevent irreversible brain injury. In Kentucky and most states, it is required to have CPR and AED training in high schools. And Kentucky has recently, this was last spring, required all schools to have AEDs in all school buildings as well as at sanctioned practices and athletic competitions. This brought a problem out because then school nurses were asked to develop cardiac emergency response plans without knowing where to start. And so Project Adam is a program where school nurses or community leaders can ask us for help. We will contact the school, provide assessment tools. We will review their already existing cardiac emergency response plan and go over a checklist. We will change things that may be loopholes in their system, and then we will do training drills and sessions. And at the end of the day, if they meet all the requirements, they are designated a heart-safe school. This is just a brief look at what the checklist looks like. We go over where their AEDs are located. Are they functioning normally? What is their cardiac emergency response plan and team composed of? Do they have enough people to cover the entire school building? For the plan, is it written? Do people know about it? One of the keys is the plan shared with local EMS because they're the ones that are going to be responding. So they need to know that this plan is in place and where to enter the school if there's an emergency. For training, it needs to be trained just like a fire drill. It needs to be done, and everyone needs to know all of the positions of the team. So there's redundancy in place. And then after the drill, you need to have a post-drill review, kind of a debriefing to say, what did we do well? What can we improve upon? There are free resources available to anyone that needs to see them at projectadam.com. And also, there are videos of how to perform an emergency response drill at any location. Again, this is school and community-based, so anyone can do this. And when we're looking at the drills, we typically will look at the time to shock, how the team responds, and they get points for each one of these different markers. And then we also look at how the team interacts with each other. Are they doing good compressions? Where is the AED placed? Is EMS involved? And do they know where the drill is taking place? At the end of the day, when we go to the school for that final designation, we go over their CPR skills with mannequins. We will run a drill that is as lifelike as possible. This drill at Spencer County Elementary School, we ran in the gymnasium during a fifth grade PE class. We dropped the mannequin on the floor while the kids were playing freeze tag, and the teachers had to respond and clear the scene. The fifth graders were very interested, so they stuck around to watch. And then afterwards, we have a debriefing going over what they did well or what they can improve upon. This doesn't just stop at the school, but it also goes out to the sports fields because a majority of the time after school hours, kids or community sports teams will be playing on their facilities. So how can we make those spaces more safe for schools? So we do perform drills out at the football field and track as well. And at the end of the day, schools are recognized as being a heart-safe school and get that recognition from Project Adam nationally as well. So where do we go from here? If anyone is interested or they have kids in school or you have a patient with a high-risk condition that you follow in clinic and maybe their parents are interested in being a champion at their local school board, really all they have to do is email us this email and we would be able to contact them and get rolling with the help they may need. And that's all I had for today. So I don't know if I have time for questions or not.
Thanks, Adam. Very interesting. Are Jefferson County schools heart safe?
We are currently not because they have been doing their kind of own initiatives. I've contacted them about it, but they have not allowed us to help in any way thus far. So we've
Very
been in
interesting.
contact with Oldham, Spencer, basically every surrounding county has been interested in the help so far. But Jefferson County has not been interested as of yet, but I'm open to helping in any way possible. We have contacted some of the private schools, which seem interested as well.
And then at what age would an adult cardiologist reading be acceptable on an EKG?
I think if they are adult size, I think that's the main thing. Some kids that we're seeing, they're going through puberty, they're still very small. If it is a well-grown senior in high school, I think that is a different story. But some of those ninth graders that come in, they're still not fully developed. Those are things that may have abnormal findings, maybe related to where the EKG leads are on a relatively small child.
All right. Thank
Yeah,
you, Dr. Scaff.
no problem.